The risk of breast cancer is not there with the use of estrogen. I had all these women that were coming in their 40s and their 30s and their 50s. It wasn't just the component of weight loss, it was also hormones on top of it.
Why aren't we talking about the benefits? Why aren't we talking about bone density? Why aren't we talking about, cardiovascular health? Why aren't we talking about, being a preventative to our cognitive functioning?
Welcome to the Hot Flash Health Podcast, where we're dishing out unfiltered truths about menopause with a side of sass and a sprinkle of grass.
Get ready to dive into the wild world of hot flashes, mood swings, and all of the other joys of being a queen eater.
This ain't your grandma's podcast. No, we are here to talk our bodies, our fears, our passions, our desires, all while navigating this wild roller coaster ride of menopause.
So grab a glass of wine,
Or three.
kick back, relax, and let's enjoy this hot flash wave together.
I'm Courtney Mamusha, and alongside me is my fabulous co-host, Dawn Fable.
We're just two outspoken broads who like to call it how it is.
Now, without further ado, let's kick off today's episode. Hi, everybody. Welcome back to the Hot Flash Health Podcast. Today, we're diving into a super important topic that we just can't ignore: hormone replacement therapy, or as we all know it, HRT. And to help us break it all down, we've got the incredible Sheri Poznanovic, founder and CEO of Optin Health and Nutrition, joining us. Sheri is a powerhouse in the health and wellness world with over 20 years of experience. She's triple board certified in obesity, lifestyle, and nutrition medicine, and has a master's in nutrition and human performance. Human performance. But that's not only the best part. She blends cutting-edge science with practical treatments like precision hormone balancing and advanced peptide protocols. Basically, she's here to help you feel your best from inside out, whether that's through hormone therapy or full-on lifestyle transformation. We're also going to chat a little bit about her own journey through perimenopause and how she's helping women today navigate this crazy ride we're all on. So, all right, Sheri, welcome. We're so excited to have you.
Oh, thanks for having me. I appreciate it.
It was a little technically challenging to start, but we got you here. So
Yeah, we got you. And we're sitting next to each other today, which is super exciting.
yeah, we're never sitting next to each other. So this is exciting.
So Sheri, I've heard so much about you. How did you get into this crazy world of wellness and performance medicine? What was sort of the light bulb moment that you had when you realized this was your calling to help so many women like us, which thank you.
Yes.
Yeah, it was kind of a roundabout way, actually. So I'm a retired surgeon. I used to be a pediatric ear, nose, and throat surgeon. So I took out a bunch of tonsils and did ear tubes and airway surgery. And I loved that. I did that for many, many years and loved being in the operating room. But I retired in 2019. And when I retired, like I sat around and I was like, what's my next journey, my next chapter of life? Because I'm not the person that's just gonna sit around and do nothing. And as I was exploring that, like what I found was like the things that I gravitated to was more wellness, more preventative medicine. Like how do I use nutrition, lifestyle to change things, even from my own life? Like I'd already done that throughout the years of like just not getting the answers that I wanted from Western medicine, things that I did to kind of help myself, sort of gravitated to those kind of podcasts. And through the process of that, I was like, okay, I'm going to start. I'm going to get my master's in nutrition, which was a whole another concept of doing that when you have kids at home, and being a full-time student was a big thing. And then my practice kind of evolved after I did that. So I started with nutrition and then realized I also like the lifestyle component of it. I got certified in lifestyle medicine, which really focuses on more of lifestyle changes, right? Controlling your stress, your diet, social connections, all of those things that go into sleep, that go into lifestyle. And as I was creating that for patients and sort of helping along the way, I found obviously like a major need, as we all know right now, is for people for weight loss and for managing obesity. And so I headed down the route of getting obesity medicine board certified trained. And in the process of doing that, I realized like it's not just about, obviously, there's a huge component of needing to treat obesity, but using different medications and using techniques to kind of help with weight management. But part of that also was hormones. Like I had all these women that were coming in their 40s and their 30s and their 50s. And it wasn't just the component of weight loss, it was also hormones on top of it. And that's when I was like, this is like mind breaking for me that I really need to to focus on everything, all of the above. And I think, unfortunately, like we kind of fall, even in people that are in the wellness community, they kind of fall in that because they're only treating one thing. You may see pop-up clinics that just do HRT, and you may see clinics that just do weight management, or clinics that just deal with lifestyle changes. They need to encompass all of that to really help somebody live their life to their best, right? I think the term of like longevity medicine, I'm not a huge fan of that because it's not necessarily how long you live, it's how well are you living the life that you're living. Women, unfortunately, our lifespan is longer than men, but we live more years unhealthy, right? And
One
how
thing,
do we correct that? Yeah, how do we correct like those years of being healthy if we're living longer than them? So that's my goal, is to help someone live their life better.
yeah, I love that. And I think, we talk to a lot of women who are like, we're sick of talking to one doctor who's like, okay, looking at like something with one lens, right? And just saying this is okay, right? So I love that you look at, from the inside out and really help women become their best. One thing that obviously we talk about so much on the podcast and going through this menopause journey is HRT. So let's just jump right into that, right? So what exactly is HRT, and why should women be talking about it more? And what can HRT do for someone who's in the thick of perimenopause and menopause?
Yeah. So HRT is, it stands for hormone replacement therapy. And there are people out there that more of a promoted of just actually saying hormone therapy versus replacement. It's just hormone therapy. And unfortunately, as we know, as we get older, we lose the hormones. First one being testosterone, which I think is sort of forgotten hormone in women, which really needs to get more attention. There currently is not an FDA indication for testosterone in women. For men, there is, but not for women. And it's just as important of a hormone as anything else. We actually make more testosterone through our life than we make of any other hormone. And so we kind of forget about that. And that's usually the first one that starts to drop in our 30s. Testosterone kind of drops, and then our 40s, progesterone starts to drop. And then by the time we actually fully hit menopause, which as we know is, 12 months of no menses is when you technically have hit menopause, then estrogen is done, right? Your ovaries are kind of done. They've retired. They've checked out. You no longer have estrogen. Unless you're making it from fat cells or other ways, but like your major component of estrogen is gone. And so through the process of that, like where do you help a woman, and where should that start? And I think HRT, for many reasons, has got a bad rap for a number of years. And I think we're hopefully kind of seeing the shift of that coming back again. If you look at the historical nature of HRT, like we've been using HRT for a very, very long time. Like women in the 50s and 60s were using estrogen as cardiovascular prevention, as bone loss prevention. It was used for women for cardiovascular disease. And then, unfortunately, so when it first started, we were just using estrogen, right? And then we realized, okay, if we're not using progesterone, we're not protecting the endometrial lining. Women are getting endometrial cancer. Okay, we add on progesterone, which progesterone, I think, is also a forgotten hormone of, it's not just to protect the endometrium. Like there are other things that progesterone does too. And so we were in that period for a long period of time until 2002, when the Women's Health Initiative study came out, which unfortunately, what came out in the media was incorrect and misinterpretation of the data. And it's been 20 plus years of trying to dispel that study. And when you break down that study of the Women's Health Initiative, so the Women's Health Initiative came out saying estrogen causes breast cancer. Women should no longer use HRT, right? And there were a large proportion of women that were using estrogen at that time that completely stopped using estrogen. And there's an entire decade of women, unfortunately, who never had that exposure because there was this belief for the longest period of time. And I think that decade of women, unfortunately, have, they're now hitting their 70s, their 80s. Like they're seeing that in bone health. They're seeing that in cardiovascular disease. Like we're seeing an increased amount of Alzheimer's and dementia. Like your grandma, may have one grandma that died from hip fracture and another grandma who's in a nursing home because of dementia. Like all of that is because they lacked that estrogen. And we lost a long period of training of physicians who weren't trained how to use HRT because of that study. And when you break down that study, the first initial wrong component of it is they were looking at the wrong population. Average age in that study was women at 65, like not women that are perimenopause, menopause, like not the people that we're looking at that are going to be starting HRT. So that was the first wrong part. The second part was that what they used was different, right? So they had one arm that was no hormones. They had one arm that was conjugated equine estrogen, which was the estrogen at the time, right? It's a synthetic estrogen. And then another arm that had conjugated equine estrogen and progestin, which is a synthetic progesterone, so not the natural progesterone in your body. What the study actually showed, if you look at the study directly, the only arm that showed a slight increased relative risk of breast cancer, meaning 1 in 1,000 chance, which is around the same amount as having 2 glasses of wine every night, being sedentary and not being active, like not being social, being overweight, same amount of risk, was just in the arm that was on estrogen and progestin. If you looked at the arm that had just, and this is not even a great form of estrogen, right? It's a synthetic form of estrogen. That arm had no increased risk of breast cancer. They actually had a decreased risk of cardiovascular disease, like 17% decreased risk of diabetes, decreased risk of bone fractures, multiple things that were seen in that arm. And that was never released. Like that was never out there. So estrogen got this bad hit of being this cause of cancer when it really was actually the synthetic progestin that had a slight increased risk. The only other thing that was found in that, and this has been sort of done in multiple studies since then, is oral estrogen. Even if it is more of a bioidentical estrogen, oral estrogen can potentially increase risks of blood clots and strokes. So not the ideal way to give estrogen. Otherwise, any other form of estrogen, we're not seeing increased risk of any of that stuff. So I think that the tide is now shifting and people starting to realize like there have been enough studies, we've looked at enough HRT, we're using different hormones now than we did. And I think women are just becoming more aware and more vocal about their needs, right? About the fact that the lack of research on women's health is so minuscule, which is a travesty. We are underrepresented in all the research that's out there. All the research there is based on men, not on us.
I don't think we're going to get any funding anytime soon.
Yeah. No, unfortunately, no. Unfortunately, no.
How many more years do we have? 3 point. Counting down. I have a countdown in my account.
You know, it's such a disservice. What a disservice that period of time was, not only for the older generation, but the misinformation that we as women now are still trying to recover from, right?
Yeah, absolutely. And it's still there. It's still there in providers. Like I have primary care doctors, I'll see patients and they'll be like, my primary care doctor said I absolutely cannot be on estrogen. And like for no reason of increased risk for anything. Or they can't be on testosterone. Like I can't do this. And for women who don't know, right? Like they've heard these similar things. And so they're scared. They come to me and they say, well, is an estrogen potentially going to give me breast cancer? So I think it's just dispelling those myths of what hormones do.
Yeah. Well, thank you for being, a pioneer and an advocate for so many of us women who could really benefit from this. You know, I find myself being in the industry, being very confused of each of these delivery methods of hormone therapy. You know, you hear about pellets, you hear about the troches that you put under your tongue, you hear about the cream, you hear about the shots, you hear about all of those sorts of things. Can you walk us women who are starting to explore this option for ourselves as to some of the practicalities and deliverables of each of these hormone replacement therapy and what you as a physician might recommend or perhaps, lean one way towards the other?
Yeah, I think ultimately it's a discussion that you have with your provider, right? And it's an individualized thing of what works for you. But I think women need to be educated. What are my options and what are good options and what I can and can't do? And then it's a shared mutual decision making of what do I want to do? And I think also along the side of the discussion of side effects, like I think it's more of a discussion of what happens if you don't take it, right? Not necessarily the effect of if I do, what's going to happen if I don't get on hormone replacement? And there are a lot of increased risks of a lot of things if we don't: testosterone, estrogen, progesterone, all of those things. So testosterone for women, a few different ways you can do. You can do shots like men. Uncommon for most women to do that. They're intramuscular shots. They're not great shots to do, and you don't need as big of a volume as men do. I wouldn't say I routinely do that for women, but that is an option. There are creams, there are gels, there are, like you said, the little troches, the sublingual things. Oral is out there, not an ideal, at least currently an ideal way to take testosterone. That's kind of shifting a little bit. And then there's pellets, which I'm sure we've all heard of pellets. So, and I think discussing all of those pros and cons of both. So with creams for any, whether it's testosterone, estrogen, whatever it may be, creams are great. Right? Creams are great. They're easy to use. They are something you have to think about to do every single day. You got to travel with it. And there are issues of absorption, depending on how clean your skin is, where you put it. The skin itself, eventually over time, the receptors on the skin will tend to desensitize. So even if you're alternating different areas with testosterone, you can get actual hair growth in whatever area you may be using the cream, which if it's on your leg, fine, like if you're shaving your legs
Put it
anyways, but
there, ladies. Put it
unfortunately doesn't work on the head. So I mean, there are downsides of using creams, but that's an option. And I think what I discuss with patients with creams is it's also a good way to start if you're kind of nervous about what you're doing. Like maybe we start low, we start slow, we start with creams, kind of see how you feel. I would say from personal experience of working with women and with myself, I didn't find like a stable sort of feel when using creams. It was just sort of more up and down depending on how well it worked or didn't work in a day and how well it absorbed. Did I put my pants on too soon and so the cream is on my pants? Like there's definitely a chance of transference of these hormones to animals. So if you're putting it on your wrist and you have a dog that licks your wrist or a cat that licks your wrist, it can transfer to animals, it can transfer to kids, your husband. I've seen that in lab values. I've seen husband with really high levels of progesterone because woman was on a progesterone cream. So it absolutely happens. Gels, similar sort of thing.
testosterone and just like rub it on my husband.
Gels are similar, right? But gels take longer to sink in. Like if you're someone that's in a hurry, like getting ready, gels aren't great. Patches are absolutely an option. Harder time if you're someone that sweats a lot, if you're exercising a lot, if you're out in the summer, like those patches don't always stay on super well. But I think it's always good for women to know all their options for all of these. And then pellets kind of be the last thing. So pellets like a newer, well, not newer, they've been around for a long time, but it's sort of a newer, trendier thing. I think that people are hearing about pellets a little bit more. And pellets are a safe way. They currently aren't FDA approved or FDA indicated. If you look at the North American Menopause Society's recommendations, they currently don't recommend pellets. I think there's just not enough research surrounding them. And I think, unfortunately, they're not being used appropriately in a lot of women. I think there are a lot of pop-up clinics in different places that are, especially from a testosterone level, are giving women super physiologic doses of testosterone they don't need. And then we actually are getting side effects from that. So I think knowing if you're thinking about doing pellets that you're going to someone who know, I mean, if you're going to stick something in someone that's going to last 3 to 4 months, you absolutely should know what the hell you're doing with it, right? Because it's not going anywhere for 3 to 4 months. It's eventually going to go away. It's going to dissolve. It's just a medication, but it's going to take 3 to 4 months depending on how quickly you metabolize it.
In the meantime, you're like walking down the street, dry humping your seams on.
Exactly. Yeah, and you get more acne, like oily skin, all those wonderful things.
Growing a
But
beard.
if you're dosing it appropriately, and I would say personally, my own, I've been doing pellets for a year and a half. I've
I
found
bet
that's
you're
the best way for
a
me.
happy guy.
Yeah. And then the progesterone, the only difference with progesterone you can take orally. Probably the best way to take it is orally. You can do it in creams transdermally, but there's definitely some data to show that potentially it's not enough protection for the endometrium. So if you are also doing estrogen, you aren't protecting that endometrial lining enough to prevent endometrial cancer if you're doing progesterone on the skin. So orally is really the ideal way to go. Progesterone is also a very calming hormone and it helps us sleep. So taking it right before bedtime does wonders for most of my women that are like in that sort of perimenopause phase of being helped with sleep, because that's obviously one of the first things that we kind of see is our sleep kind of going wacky and all over the place.
Yeah, so let's talk about that for a minute because so many women are getting these, blood tests, and we're actually really excited to launch our Hot Flash Health at-home blood test, which we would then, it's really just a acknowledgement for a lot of women who feel something is off, an easy way for them to be validated, right? That
Yeah.
something is off. And then obviously this, the recommendation would be to go see someone like you who can put together a really customized plan for that. But with a lot of these testing components, you show these ranges, right? You're low in testosterone or you're high in estrogen. What are the indications for women? What are some of the really early signs that our hormones might not be within their ideal range for each of the hormones?
Yeah. And I think when it comes to ideal ranges, I think that's also tough, right? Like
Yeah. Like, what if
testosterone.
you don't want to be like in the middle?
Yeah.
What if you
Yeah.
actually want to
Yeah.
be in an optimized position to
Right.
feel your best? We shouldn't
It's like
settle.
it's like looking at a bell curve for your kids, right? Like, do you want your kid to be over here at 90% or do you want to be at the 10th percentile, right? Like, I don't want my kid to be over here at the 10th percentile. I want them over here. Like, and that's to go with progesterone, testosterone, estrogen, thyroid, which is also a whole other discussion. How I think there's definitely probably some thyroid hormone insufficiency in a lot of women that we are under treating. Whole
Cortisol,
separate
cortisol,
discussion. Cortisol for sure. So yeah, and the reference ranges are kind of vague, especially with testosterone, depending on the lab. There are some labs that show a bottom level is 0 as normal for women. And
Oh
we
my
know
gosh.
0 is not normal
Yeah.
for women. And it is hard to know because every woman's different. If we all were tested on our genes, our testosterone levels may have been very different. Our estrogen levels may have been very different. So we don't know. I may be different than you or someone else of the levels that we need. And when we test in the serum, especially with estrogen and perimenopause, which is a really tough hormone to kind of manage in perimenopause, you can, but it takes more nuances to be able to figure it out. But you can test one day, you can test one part of the day early in the morning and later in the afternoon. It may be all over the place, right? It kind of like an estrogen to like you have like an empty ketchup bottle, almost empty, right? And you have periods where you squeeze and squeeze, like nothing comes out, and then all of a sudden it's like all over the place. Like that's what estrogen does for 10 years in perimenopause for women. Like it's either nothing or there's tons of it. Every day is different. So when you test it during perimenopause, you may get a level that's high, but the next day it may be low. So estrogen is kind of a fluctuating thing. And even treating, if you're going to use estrogen during perimenopause, like knowing how to cycle through that and use that appropriately in women for those high periods when they are already high on their own, you're throwing estrogen on top of that. They're going to be more estrogen dominant and they're going to have issues from that.
I mean, I feel like HRT is just becoming so controversial, right? I mean, obviously it's been for years, but some circles are like, well, what are you doing and why are you doing that? And I have one friend who's doing the pellet and another friend who's like, that's crazy. Why would you do that? So what are some of like the biggest misconceptions out there or myths about HRT that you wish more women knew the truth?
Yeah, I think the biggest one that we talked about already is obviously the risk of breast cancer. Like the risk of breast cancer is not there with the use of estrogen. Definitely not there with the use of testosterone. Testosterone actually used to be used in Europe for metastatic breast cancer. So it actually decreases the risk of breast cancer and decreases the risk of breast cancer recurrence in women. So absolutely, I feel like any woman who's had breast cancer should be on testosterone. Those women should be on testosterone for sure. I think the myth of all the things potentially that we're not recognizing, right? So this goes to the what if we don't take it? What are the potential if I don't go on HRT? So your increased risk of bone like osteoporosis significantly higher if you don't, and that involves all three hormones because all three hormones are involved in our bone health: testosterone, progesterone, estrogen. Increased risk of osteoporosis, increased risk of cardiovascular disease. That's why we see cardiovascular disease risk go up equal to men after women over the age of 50 because we lost estrogen. Increased risk of dementia, which is something we definitely don't talk about enough. There's much higher chance of developing Alzheimer's. If you look at women who have had their ovaries removed surgically, if you do cognitive scoring tests on them before they have them removed and afterwards, it only takes 1 month to see a significant change in cognitive scores just from not having estrogen. 1 month, that's all it takes. There also was brain imaging study done of women who were in perimenopause, what their brain imaging looked like versus a year to 2 years after they hit menopause, and the deposition of amyloid deposition, which is what we see with Alzheimer's, was significantly higher within a year to 2 years. These are things we don't talk about. Estrogen also decreases your cholesterol level. It also decreases insulin resistance and diabetes. Like there's so many, and it helps from a weight. I don't use HRT for weight loss, but what I use it for is that shift in body composition, right? So that shift in body composition, because when you lose estrogen, you build up that weight loss or you build up that weight in your abdomen, sort of that visceral central adiposity that we kind of like all women get as they start to hit perimenopause. And you're like, I'm doing all the things I did before. And all of a sudden, like I had this belly that I never had before. That's why your estrogen is low, right? So HRT over time shifts that body composition, especially with the addition of testosterone to kind of help build that muscle mass up and get rid of that fat mass loss. It's not my first go-to for a weight management standpoint, but it adjusts from that. So I think that those are the things that we really need to get clear is what happens if you don't? Happens if you don't? And again, it's every woman's choice whether or not they want to, but I think it's an educated discussion that every woman should have. This is what's going to happen if you take HRT, and these are potentially the risks, which are pretty minimal if you don't do HRT. So that I think is what I would dispel.
Yeah.
And the breast cancer one, like I think that one has been beat into the ground that it like is not there.
Yeah.
So much goodness here. I mean,
Yeah.
so much goodness and so many benefits from
Yeah.
HRT
And
that we're
And
not
when you
talking
ask,
about just the
yeah,
risks, right? Why aren't we
yeah.
talking about the benefits? Why aren't we talking about the bone density? Why aren't we talking about, cardiovascular health? Why aren't we talking about, being a preventative to our cognitive functioning?
But I already feel like I have dementia. I'm forgetting everything right
You
now.
know, it's
So
it's
that's
interesting.
interesting.
It's interesting because with the loss of that estrogen, I feel a very noticeable
Yeah.
difference in my
Oh,
executive
yeah.
functioning, in my memory.
Sleep.
I used to multitask
Yeah.
incredibly well, and it's almost like there has just been this shift in not being able
To
to
remember
do
anything.
things as well as I once did, and it's so refreshing to hear someone like you say that no, you don't have an early onset of Alzheimer's, you're not dying. This is actually very normal with your estrogen decrease, and let's do something about it. So thank
Yeah.
you.
Yeah. And when you ask like sort of symptoms of like, how do I know when I need replacement? Like, I think, especially in like in your 30s, you kind of start to lose that testosterone, and testosterone is sort of our driving hormone, right? Like, it gives us our drive to do things. So to get up and go, whether it's not even necessarily just to the gym, but just to do things in life, it gives us that sort of sense of overall well-being, our confidence. Like, that's what testosterone does. So that kind of drops. And then when progesterone starts to drop, progesterone is sort of our calming, like grounding, centering hormone. We lose that, and we all of a sudden are like,
Want to
I don't
slap
know,
everyone you
like
see, like
things are all over the place, right? And then as estrogen is kind of all over the place in those huge fluctuations, like the wheels kind of go off the bus, right? The wheels go off the bus and you kind of fall off a cliff is what happens. And I think that's actually like, I love using analogies, but like we were skiing 3 years ago in Aspen. I don't know if you've ever skied Ajax. Like, it's a pretty difficult mountain. And my son, like, we went over spring break, and right before we got there, they got like 2 feet of snow. So like the snow at the beginning of the week was fabulous. Like, we had these runs we were doing throughout the day. Right at the end of the day, we always would take a double black down, and then we do this traverse over and then like drop down to our condo, right? And throughout the week, the snow became less and less because it was sunny and it was spring, and like you had to appreciate like the change in terrain. And by the last day, it was the last run of the last day, which is always what happens, right? Last run of the last day, and I think he jinxed himself because he said to me, Mom, this is your last run before you turn 50 this year. You got to make this a good one. And I was like, oh, thanks, Tyler. Right? So we get down, and he hits the traverse, and he had this traverse, and it was like, this 6-7 foot wide traverse that he'd had this little jump that he'd done every single day, kept going, he was doing fine. And like, my kids are great skiers. He hit this bump and didn't respect the terrain, right? Didn't respect the terrain and the change in terrain, which is kind of what we're going through in the middle of perimenopause. We don't know what the terrain is anymore. All of a sudden, it's shifted every single day. And he hit a patch of ice and went headfirst off the edge of a cliff, right? And I think that's what happens, right? Like, we don't respect that change in terrain, and all of a sudden we just like fall off. We fall off the edge of a cliff, and then we kind of get lost down there. Like, if we don't have someone to help us, we're just lost waiting around in like 2 feet of snow, which is kind of where he was until we got him back up off the edge of the cliff. Like, that's where you are when you hit this. And if you have someone to kind of help you navigate through that, and whatever your symptoms may be, because every woman is different, right? Like, not everyone has hot flashes or night sweats. Some people have mood issues. Like, everyone's a little bit different of what they may experience. You need someone to help navigate you to get you back up and out of there.
Were there, I know obviously you've gone through perimenopause, going through it. Were there certain things with your own journey that made you kind of look at health differently and say, okay, well, I'm having these night sweats. Like, how can I help other women? And did that really change your approach to how you're treating your clients right now?
Absolutely. I would say, like, looking back, like, and I think we all do this, right? Like, once we're sort of in the thick of it or past on the other side, like, we're like, oh yeah, I probably had some subtle symptoms that I just didn't appreciate was perimenopause for years. But when I was, I guess probably around 48 was when I got like full on, like, my biggest component was like mood disturbances, which is not me. Like, I'm a pretty happy person. I'm never anxious. Like, I was a surgeon. I can make life and death decisions. Like, nothing like made my heart rate like super fast. And all of a sudden I was having like panic attacks. I grew up in Colorado. I can drive anything in any weather. And I would have days that, like, if it was raining, I couldn't get behind the wheel of my car. I would call my husband and I'd be like, I'm out I can't drive carpool today. I can't. And he's like, it's just raining. And I'm like, I know it's just raining, but I can't get behind the wheel of a car. I was a totally different person. Like I was not myself. And I mean, I had other changes too, like body composition had changed, like the same workout that I'd done for years, all of a sudden, like my strength wasn't there and I was losing muscle mass when I've never had that issue before. It was so many things, but the mood was the biggest component for me. And within like for me, within starting a month of starting HRT, I was back to myself, completely back to myself. Like that was all gone. And I think people don't appreciate that. Like the highest amount of depression, the incidence of depression is diagnosed in women age 40 to 59, right? So women that are going through menopause. And unfortunately, like when I went to my primary care doctor with these symptoms, she wanted to just put me on an antidepressant.
Yeah, I was gonna
And I
say.
said, I don't think that, like, I don't think that's it. Like, I don't think I just need an antidepressant. Like, I think there's something else going on because this is not me, right? And it wasn't, right? It just,
Can you still hear us?
We can see you.
oh, I can now.
Okay,
Yeah.
there you go.
I can now. It says it's reconnecting.
Try to
Can you hear
reconnect.
me? Yeah. So that just having my own knowledge of going through it was even more of an incentive to say, you know what, like not only do I need to help my patients from the standpoint of like losing weight and addressing their hormones and cortisol levels and everything else, but my own experience of having that and not getting someone to help me without my own advocacy, right? Like I had to search that out and find somebody to help me. That made me really advocate for women because I mean, this is where my friends are, right? Like I'm now on the other side. I'm in menopause. I have my HRT. Like I'm good. I'm happy. I'm at a set level. And I will tell you, like I had a patient tell me who has CPAP. He said, if my house was on fire, like this is how important my CPAP machine is to me. I would leave the house with my CPAP machine before I would my kids and my pets, right? Like if I could grab my HRT, that would be the first thing I would grab before I grabbed anything else and before my house was on
That
fire.
sounds great
I
to
will
me.
go to the I will go to the grave with my hormones. And that's also a whole other myth I think that has slowly getting dispelled is like it used to be the lowest amount of treatment for the lowest amount of time. And that's stupid. Like if you've been on HRT, there's no reason to come off. And there's so many studies now showing that like you can be on HRT to your 70s, your 80s, your 90s. Like there's no downside to it.
Yeah.
Yeah.
Yeah. Well, we so appreciate all of your knowledge. I mean, obviously, your practice, comes from a very purpose driven personal place of wanting to help women feel their optimal levels. But you do so much more than HRT, right? You really look at an
Yes.
overall wellness, comprehensive wellness plan and individualize that to each person. What are some of the other things, Sheri, that you are doing within your practice or you are seeing beneficial for women going through this hormonal journey?
Yeah, my practice focuses on overall wellness and performance for women, right? So again, back to that health span. Like, are we living the healthy life that we want to live rather than where we should be thriving, right? Like not just surviving. So I may have a woman come in and have just issues with weight. But it may not just be weight, right? Like it's weight, it's hormones. The other things I also look at in particular, stress. Like stress is for all of us is a chronic thing, right? And stress is a normal thing, but I think we live in this very chronically stressed world and we're not appreciating enough our cortisol levels, whether they're too high, whether they're too low, and that affects our weight, that affects our mood, it affects our hormones. Interestingly, too elevated levels of cortisol is going to decrease thyroid production, is going to decrease progesterone. Like there's so many things that it also is going to affect. I address sleep with women, which is incredibly important and we know does not get better when we're in our 40s and our 50s, right? So sleep is a key component for so much for women. And connection, social connection, like making sure women have that, and spiritual connection, sort of your meditative, whatever that may be for you. Like self-care is a big thing. Like it's not a selfish thing, it's a legit thing. Like you show up better in the world if you're taking care of yourself and if you have all that. So I focus on all of those things. I offer like I do a lot with weight loss, being, obesity board certified. Like I offer GLP-1s, I do things like that. But I also, along that process, we deal with hormones, we deal with weight loss, we deal with addressing cortisol, whether it's, nutraceuticals or different things to kind of get that cortisol under control. I also use peptides, which peptides are essentially just smaller proteins, right? They're just shorter chains of amino acids is what peptides are. GLP-1s are actually a peptide. That's all GLP-1 is a peptide. Insulin is a peptide. There are several that are out there. Unfortunately, there were several that were taken off the market for no particular reason by the FDA within the last couple of years. So the market kind of shifts in knowing what peptides are there, but there are some that are help for weight loss. There's some that help with GI issues, some that help with healing, like several different ones, and kind of making sure we're able to use that. As I expand my practice, which within the next couple of months, we're opening up a larger office, I will be delving more into IV therapy, in particular using NAD, which NAD is sort of a second cousin like molecule to niacin or vitamin B3. But what it essentially, it's like cellular health, right? So you have physical health, you have mental health. Like this is like cellular health. Like how do you rebuild the mitochondria of your cells, which is we all learned long ago is like the little powerhouse of our cells. That's what NAD does. As long as you're using it appropriately. There are a lot of IV places that may put NAD in something, but I think you need to know an appropriate protocol of a high enough dose and needing to do it at least 5 treatments within 10 days to really maximize what your mitochondria are going to do, and then sort of maintenance after that. So that's my next step into evolving, is making sure all of that is included as well too. I also work in conjunction with a lot of people. I work with wellness and health coaches, which definitely help with my population of people that are struggling with their weight, of like getting past those barriers of I don't have time to work out, or I don't have time to make these things. Like how do I address these things? They coach you through that, right? Like similar to another skiing example is like when my kids first started skiing, I put them in ski school, right? And I stood and watched them on this like short little bunny hill, and it took like 10 minutes for like kids falling off to the side or like they couldn't get back up. And these incredibly patient, wonderful instructors, right, were like helping them figure out like, how do I get myself back up again? How do I get back from veering off from somewhere? Like that's what a health coach does, is it helps you do that, get through those times when like things may get stuck and you may lose things. And again, those wheels may fall off the bus because life sucks sometimes. I also work with a PT personal trainer. I have an acupuncturist that works with metabolism. She deals with metabolism for my weight loss patients. She also does facial acupuncture, which is fabulous. I have a chiropractor. Like I have tons of people that have sort of that whole health picture to really help women feel their absolute best.
I love that. Well, we loved having you on today. You're such a wealth of knowledge. I know we've learned, so much about HRT and you personally, your journey and how to ski Ajax in the spring or not. And tell people where they can find you, right? Obviously you're in Denver with us, which is great. So anybody looking to connect with you, how can they find you?
Yeah. So my website, and you can call, but my website is Optin. So it's OPTIN, the number 4 health.com. And then my phone number is 303-495-9013. More than happy to chat through. We usually do an initial like 30-minute phone consultation to kind of get the feel of like what people want, see if we're a good fit, see if people are interested in what we have to offer, and how we like, again, aren't just addressing hormones, we're addressing overall health for people to make sure that they're optimized. So.
Ladies, put that number on speed dial. Sheri, do you see people virtually and outside of the Denver market?
I do, yeah. Actually, I do telehealth here in Colorado. So people who aren't super close to me in Greenwood Village, I do like to see, especially people who are in Colorado for initial visits. I do like to see people in person initially, just because that's me. I spend an hour. My initial visit is in 60 to 90 minutes with people, just to getting to know them and what their goals and their desires and needs are. But I also am licensed in several other states, so there are other states that I can see patients too.
That's so rare that a practitioner takes the actual time. They're so often like rushed in and out, trying to get onto the next thing, prescribe. Yeah. The fact that you're doing that, we're so grateful. And we're so grateful for you educating all of us women. And like we said, ladies, put her number on speed dial. I know I'm certainly going to come in and see you. So thank you.
Yeah, absolutely. Thanks for having me on.
Yeah,
you got a wrap.
Yeah. Well, I'm sure we'll have you back. So we will just finish today with saying thank you guys for all listening and for hearing Sheri's story. Optin is amazing. Brand new website. So shout out to her beautiful new website. Please subscribe to Hot Flash Health on all your social channels, as well as follow us, listen to us. This is a community. If anybody has any ideas for speakers, we are all ears, and we are building this together, one hot flash at a time. So until next time, stay classy, sassy, and keep those hot flashes in check, y'all.
Well, thank you. Mwah!
And that's a wrap on today's episode. Remember, menopause may be a wild ride, but together we've got this.
And don't forget to follow us on Instagram, Facebook, TikTok at Hot Flash Health.
Stream and subscribe to us on any of your favorite listening platforms like YouTube, Apple, and Spotify.
And of course, share your thoughts with us. We love hearing from our amazing listeners.
And until next time, stay sassy, stay fabulous, and keep those hot flashes in check.
Yeah, girl.
Woo!